This is the University of Kentucky Department of Anesthesiology YouTube channel, and this is part 3 of 3 of Anesthesia Pharmacology Keyword Review, focusing in this part 3 on continuing volatile anesthetic keywords, pharmacokinetic keywords, and miscellaneous pharmacology topics. As a reminder, the pharmacology keywords from 2019 and 18 are in the next several slides, but this review covers over a dozen years of American Board of Anesthesia keywords. On the topic for this last part 3, inhaled anesthetics, Meyer Overton correlation, postoperative nausea, nitrous oxide, air expansion, geriatrics and MAC alterations, intraocular gas contraindications, some miscellaneous pharmacologic topics like context-sensitive half-time, dexmedetomidine and its cardiovascular effects, ketamine and its effect on BIS, prolonged QT interval, renal insufficiency and sedation in the ICU, diuretics, emergence delirium, metoclopromide, acute intermittent porphyria, geriatric patients and dosing differences, glaucoma, and management of postoperative nausea vomiting, ketamine mechanism of analgesia, and ECT seizure duration. Some of these topics have been covered in part 2, but we will now focus in on miscellaneous pharmacologic topics, pharmacokinetics, and finish up the volatile anesthetics. Gaps in knowledge in 2019, at which more than 50% of people missed this question, that the application of charcoal filters to your inspiratory and expiratory limbs of the anesthesia machine's breathing circuit is a way to reduce further exposure to volatile agent during an intraoperative episode of malignant hyperthermia. That was one gap, and another one was the use of the herbals ginseng and garlic as herbal supplements does not represent a contraindication to spinal anesthesia. In purple represents 2019 throughout this slide presentation, and in green represents 2018 keywords. And if we look at the inhaled anesthetics and miscellaneous pharmacologic topics from 2018, things like blood gas coefficient, carbon monoxide production in the CO2 absorbent, mechanism of action of inhaled anesthetics, mist-filled vaporizers and calculating the output, stages of anesthesia, DES versus SIVO, MAC and factors affecting it, nerve gas and treatment, medications that prolong QT interval, glycopyrrolate and its side effects, treatment of postoperative nausea, how diuretics work, and 3 questions actually on diuretics. So let's move in now to our pharmacology keyword, part 3, focusing on inhaled anesthetics, continuing our previous discussion in part 2, pharmacokinetics, and some miscellaneous topics, starting with vaporizer filling air. If you are trying to figure out what happens when you misfill a vaporizer, what's going to happen, you need to know the vapor pressure of the inhaled anesthetics as well as MAC. Vapor pressure is proportional to temperature. As temperature goes up, vapor pressure goes up, but it's independent of atmospheric pressure. So the vapor pressure of isoflurane is approximately 240, whether you're at sea level or up at Denver at about a mile high. Desflurane's vapor pressure is the highest at about 670, ISO at about 240 millimeters of mercury, SIVO at 160 millimeters of mercury at 20 degrees centigrade. MAC, 1.2%. ISO will keep 50% of patients from moving to incision. 2% SIVO and 6% desflurane is MAC. So let's give an example now of a vaporizer filling air. If you put isoflurane accidentally in a SIVO vaporizer, what would happen? Well, let's set the dial to 4% SIVO. We think it's SIVO. We thought it was SIVO. 4%, so that would be 2 MAC. We think we are delivering. But the vapor pressure of isoflurane is greater than that of sevoflurane. Therefore, it's going to deliver more than 4% of the gas that's in it, which would then be greater than 3 MAC isoflurane instead of just 2 MAC of SIVO. So you'd be overdosing a patient relatively. If you happen to put DES, if you could, in an isoflurane vaporizer, when you turned on the isoflurane vaporizer, there would be a high delivery of the gas because the high vapor pressure of desflurane results in rapid and very high overdose from its high vapor pressure, and we need that special vaporizer that desflurane is delivered with that keeps it at 2 atmospheres and 39 degrees so that we can deliver it at a known concentration. Anesthetic delivery at altitude. What if you took a vaporizer that was calibrated at sea level up to high altitude? Well, you need to know MAC as a partial pressure, and you need to know vaporizer function with changes in atmospheric pressure. So let's give two examples here. The desflurane vaporizer, Tech 6, if it was calibrated at sea level and set at 1 MAC or 6%, you will deliver 6% at whatever altitude you are at, because the desflurane vaporizer is in its own atmosphere. It's a controlled delivery system. Desflurane 6% at sea level, or total pressure at sea level, is 760 millimeters of mercury. So 6% times that equals 46 millimeters of mercury. And therefore, you could express desflurane MAC as 46 millimeters of mercury. That's the partial pressure that causes 50% of people from not to move to incision. But if you were up at altitude, let's say up at 7,000 feet, where the partial pressure is only 600 millimeters of mercury, that is, the total pressure is 600 millimeters of mercury, you'd take 6% des times the 600 now, and that's only 36 millimeters of mercury. So that's less than the partial pressure being delivered at sea level. Therefore, you'd have to turn up the dial percent above 6% to try to deliver the same partial pressure. Otherwise, you would underdose the patient. So you would turn up the dial of the desflurane vaporizer that was calibrated at sea level to deliver the same partial pressure at altitude. Now, the isoflurane vaporizer is a variable bypass vaporizer that's calibrated at sea level, and if you set it at 1 MAC or 1.2%, it changes its output depending upon ambient pressure, unlike the desflurane vaporizer. So let's say you set the isoflurane vaporizer to 1 MAC, 1.2% at sea level times 760 millimeters of mercury. That would be 9 millimeters of mercury, or 1 MAC expressed as a partial pressure. The isoflurane vaporizer with its dial set at 1.2%, while at altitude, will actually deliver more than that. And the way I like to think of that is the liquid isoflurane sitting in the vaporizer, and the pressure above it, the atmospheric pressure, is less at high altitude, so the gaseous molecules jump up from the liquid state phase to the gaseous phase easier because there's nothing pressing down on them quite as hard. And the dial, even though it's set at 1.2%, will actually deliver a higher percentage. But what's interesting is it is a constant partial pressure deliver, and you don't have to have a percent dial change needed. So you'd leave it at 1.2%. You'd actually be delivering a higher percent than 1.2%, but now instead of 1.2% times 760, it would be maybe 1.4 or 1.5% or something like that times 600, and you end up with a very close same delivery of millimeters of mercury, and no change is needed to that isoflurane variable bypass vaporizer. It self-calibrates basically, or self-calibrates partial pressure delivery. Uptake and distribution refers to the FA over FI versus minutes of delivery of a volatile anesthetic. FI is alveolar fraction, FI is inspired. So basically, when what you have on the dial, inspired, is equal to what's in the alveolus, the ratio becomes 1. So if you set your dial at 6% desflurane, when in the alveolus it equals 6% and there's equilibration reached, the ratio of FA over FI is 1. So it's the speed of onset, basically, of the rise in the concentration in the alveolus versus what you have on your dial. And you can see, if you line these up, that desflurane is faster than SIVO and faster than ISO and faster than historic halothane. And the reason for this is that blood gas solubility is related to the speed of onset. The lower the blood gas solubility, DES being the lowest, SIVO next, ISO next, relates to the speed of FA over FI. Notice that nitrous oxide has a higher FA over FI. Wait a second. Desflurane's blood gas solubility is 0.42 and nitrous is 0.49. Why does the nitrous oxide then have a faster FA over FI? And the reason is that we deliver it as a greater inspired concentration, and concentration effect explains why nitrous oxide has a faster FA over FI than does desflurane. For example, if you delivered 6% nitrous oxide and 6% desflurane, the blood gas solubility of desflurane is lower and you would have a faster onset. But we don't deliver 6% nitrous oxide. We deliver maybe 60% nitrous oxide. And concentration effect helps it speed up and be even faster than desflurane, despite this blood gas solubility effect. A low cardiac output will increase FA over FI, less blood going by the alveolus, picking up the gas. Second gas effect, probably not real clinically significant, but if you delivered nitrous oxide with a volatile anesthetic, as the nitrous oxide is taken up, it concentrates the volatile anesthetic left in the alveolus and speeds the onset of the anesthetic state. What things decrease the uptake or the speed of FA over FI? Well, high blood gas solubility, so ISO is slower. High cardiac output, lots of blood going by the alveolus and picking up the agent. A soluble agent, more effect than an insoluble agent. So isoflurane would be affected more than desflurane by high cardiac output. A right to left intracardiac or intrapulmonary shunt. Let's say you main stem intubated someone, accidentally put the tube down 27, 28, and you're breathing only into the right lung or ventilating only into the right lung and delivering an anesthetic only to the right lung. You have a dilutional effect of the shunted blood from the left lung that would contain no anesthetic on the partial pressure of anesthetic coming from the right lung, which is being ventilated. And this decreases the FA over FI. And this affects insoluble agents like desflurane more than soluble agents. Second gas versus concentration effect. The concentration effect says that the greater the inspired concentration, the greater the rise of FA over FI. And on the far right graphic in red, you can see 10% nitrous oxide versus 70% nitrous oxide, and 70% nitrous oxide has a faster FA over FI. The second gas effect is shown at the bottom right in black, where, first of all, 0.5% halothane is administered in 10% nitrous oxide, and then 0.5% halothane is administered in 70% nitrous oxide. And as the nitrous oxide is taken up, it concentrates the volatile anesthetic in the alveolus and speeds the onset of the anesthetic state. Nitrous has an extremely high partial pressure. We're delivering high concentrations of it, despite its low solubility, and it leaves the alveoli rapidly, concentrating the potent agent and increasing the FA. And that is second gas effect. Uptake and distribution, comparing two populations. This is a key word in the past, infants and pregnancy. Infants, volatile anesthetic uptake is more rapid than adults. Why? There's somewhat smaller functional residual capacity. Number one, there's greater proportion of the cardiac output that goes to the vessel-rich group. There's a higher alveolar ventilation. And the fourth, the inhaled anesthetics, which tend to be lipid soluble, are less soluble in infants. Why? Because infants are more water. Okay, so these are four reasons why infants have a more rapid uptake, FA over FI, of a volatile anesthetic than does an adult. In pregnancy, volatile anesthetic uptake is also more rapid. Why? Increased minute ventilation and low FRC contribute. Biotransformation refers to the breakdown or metabolism of volatile anesthetics. And historically, halothane was broken down the most, about 20% metabolism. Sevoflurane is about 2 to 5%. ISO, 0.2%. Desflurane, 0.02%. Nitrous oxide, less than desflurane. And xenon is not broken down at all. In the United States, xenon is more of a research gas rather than an anesthetic gas. So, of the modern volatile anesthetics, sevoflurane is the most metabolized, and nitrous oxide would be the least, although if you compared sevo, iso, and des would be the least metabolized. Problem with des is in a dry CO2 absorber exposed to desflurane, carbon monoxide can be formed, and the way that you discover that is sending off a blood gas, putting it through a carboxyhemoglobin measurement in a coaximeter, and comparing oxyhemoglobin versus carboxyhemoglobin. You should have very little carboxyhemoglobin unless you're a heavy smoker. You might have 7 to 9 or 10%, probably less than 10%, even if you're a heavy smoker. But if you were exposed to desflurane in a CO2 absorber that's dry, carboxyhemoglobin could be formed. Sevoflurane, in the presence of CO2 absorber, can form compound A, which we worried about damaging kidneys in the past. It does damage rat kidneys, which have certain enzymes that we do not. And compound A appears to not be a problem for human kidneys. immune-mediated hepatic injury or liver-associated injury. Halothane was the classic one with halothane hepatitis in the past. Enflurane, isoflurane, desflurane, these anesthetics have been associated in the past, but very, very rarely, not with sevoflurane apparently. So halothane hepatitis was an association. Our current volatile anesthetics extremely rare to be associated with immune-mediated hepatic injury. Free fluoride ion, well, sevoflurane is the most metabolized, and there's lots of carbon fluoride bonds in our volatile anesthetics, and so sevoflurane results in the highest free fluoride ion levels between sevo, iso, and des. But unlike historical methoxyflurane, which when it was metabolized and produced lots of free fluoride ion, and when it got greater than 50 micromolar, it caused high output renal failure from ADH not being able to have its effect at the kidney. Sevoflurane's fluoride ion doesn't appear to do that, and you don't get high output renal failure. National Institute of Occupational Safety and Health recommendations for trace gas concentrations in the operating room for a halogenated agent alone, like iso, des, or sevo, it's 2 parts per million. That was a key word in 2018. Nitrous oxide alone is 25 parts per million, and if you combine nitrous with a halogenated agent, the halogenated agent recommended parts per million is dropped to 0.5 parts per million. So 2 parts per million when you're using sevo, iso, or des in the way that we often administer it in the operating room. A gap in knowledge in 2019 was that application of charcoal filters to the inspiratory and expiratory limbs is shown in this picture. They're the orange filters. And you put those in the breathing circuit. It's an effective method of reducing further exposure to a volatile agent during an intraoperative episode of malignant hyperthermia. Now, one thing you can do is just take your machine out of the circuit and use a ambu bag with oxygen. But if you're using your circuit and you're worried about getting more volatile anesthetic to someone, you can scrub it with charcoal filters in the inspiratory and expiratory limb. If you're preparing a machine that you want to use for someone who's MH susceptible, before anesthesia, you don't need to prolong flush it for high liter flow rates for a long period of time. You can put these in 90 seconds with a charcoal filter, get rid of any residual volatile anesthetic in that machine. They can be used during an acute MH crisis to limit further exposure of a patient to a volatile anesthetic. Cardiovascular effects of volatile anesthetic. Next key word. What do they do to the heart? Well, volatile anesthetics decrease the blood pressure. As we raise the delivered concentration, we expect the blood pressure to go down, and they do mainly by decreasing peripheral vascular resistance or causing vasodilation. There's a reflex and increase in heart rate and maintenance of cardiac output. The volatile anesthetics do prolong the QT interval on the electrocardiogram, but they have been safely administered with patients with QT syndrome, prolongation problems, and so moderate inhaled anesthetics can be delivered to patients with QT prolongation. Beta blockers are the therapy for people on QT syndrome prolongation issues, and these patients that are on beta blockers can be delivered moderate inhaled anesthetics without worrying about prolonging it more and causing potentially torsades de points. Of course, if you wanted to take that out of the equation, you might decide to use some form of Tiva anesthetic. Desflurane and the sympathetic nervous system. Desflurane activates the sympathetic nervous system, increasing norepinephrine, and this occurs when you rapidly increase the concentration of des, like at the beginning of a case, you intubate someone, turn on 10%, or in the middle of a case, you're on 4% and suddenly turn it up to 12% when they move. It is a transient minutes that this rise in norepinephrine and increase in blood pressure and heart rate occurs. It's likely due mainly to the stimulation of the medullary receptors via irritant receptors in our airway. So it's desflurane stimulating the airway irritant receptors, brainstem, reflex increases in sympathetic nervous system activation, and increases in norepinephrine. You would worry about this in a person with coronary artery disease, but it's not contraindicated, and desflurane has been administered to people with coronary artery disease safely. How about the volatile anesthetics and what they do to the brain? Well, first of all, they put the brain to sleep, and the brain uses less oxygen. So there is a decrease in CMRO2, or cerebral metabolic rate for oxygen. Unlike the intravenous anesthetics, which also decrease cerebral blood flow, the volatile anesthetics are cerebral vasodilators. So at the same time that oxygen use is going down, cerebral blood flow is going up. Now, this increase in cerebral blood flow can often be blunted somewhat by hyperventilation, and the increase that intracranial pressure that can occur is blunted by hypocapnia. So hyperventilation is something that we can do to blunt the increase in cerebral blood flow that occurs with our volatile anesthetics. What do they do to the electroencephalogram, DES, ISO, and SIVO? Well, the frequency tends to go down, so that means at the top right, the awake state of a high frequency, lots of little wiggly lines. As the person goes into a surgical anesthesia state, you can see that the frequency has gone down more towards delta and theta waves and higher amplitude. This is the slowing and the increase in amplitude, the decrease in frequency that occurs classically with volatile anesthetics. And as you turn up the volatile anesthetic to high concentrations, you can get burst suppression, which is flattening followed by activity, followed by suppression. And if you turn it up very high concentrations, you can get isoelectricity or a flat EEG, which would then your BIS would be reading 0. Sevoflurane is associated with emergence delirium in kids that is not necessarily decreased with concomitant midazolam preoperative medication administration. It seems like you would be able to reduce it with midazolam, but sevoflurane is a problem potentially with this delirium, and dexmedetomidine now is being used intraoperatively in patients that are young, and you worry about postoperative delirium. Now, in some of the studies, these kids might be have having pain, which could confound the factor of this association. But in general, we think of sevoflurane being associated with a higher incidence of emergence delirium in children when it's being used as the volatile anesthetic. What happens to monitoring of the spinal cord with our volatile anesthetics, like somatosensory evoked potentials and motor evoked potentials, like used during scoliosis surgery, this type of neuromonitoring? Well, our volatile anesthetics decrease not only the height of the SSEP signal, but make the signal take longer to get through. So at the bottom right, you can see a stimulus followed by a latency, and that latency or time from the stimulus to it's recorded, it takes a longer time to get through, and the height of it goes down. That's the amplitude. Motor evoked potentials are very sensitive to the volatile anesthetics, and when we're using motor evoked potentials with SSEPs, we will use a TIVA-based anesthetic in general, like propofol and remifentanil, because of this high sensitivity, volatile anesthetics knocking out the motor evoked potentials. Stages of anesthesia, kind of historical, these stages, but we think of stage 1 through 4, stage being awake, stage 2 being the one that we want to avoid, the excitability. When kids are undergoing an inhaled volatile anesthetic induction, they start thrashing around in stage 2, and then they settle down in stage 3, which we call surgical depth anesthesia. And we don't want to slip into stage 4, which would be brainstem suppression. Volatile anesthetics, what do they do to the respiratory system? Patients tend to hypoventilate, and their CO2 goes up in their blood arterially as well as their end tidal. And their apneic threshold goes up when they're spontaneously ventilating. The pattern tends to be one of panting. That is, when you're breathing sevoflurane through a laryngeal mask airway without any other drugs administered, let's say in an ambulatory setting, how does a patient breathe? Oftentimes with a respiratory rate fast, like 25, and oftentimes with a low tidal volume, like 250 or even less. So this low tidal volume, fast respiratory rate is the pattern of volatile anesthetics. They increase the volume of dead space to tidal volume. Why is that? Because dead space stays constant at about 150 mils, or 1 mil per pound, or 2 mils per kilogram in a normal person, while if your tidal volume goes from a normal of 450 while you're awake down to, let's say, 300 while you're breathing sevoflurane through a laryngeal mask airway, the ratio went from 30% going to dead space to 50% going to dead space. And then you can see why, at least partially why, your end tidal CO2 rises while you're breathing a volatile anesthetic. There's a decreased ventilatory response to both hypoxia as well as carbon dioxide. It only takes just a little bit of a volatile anesthetic on board, like 0.1 Mac, to blunt the ventilatory response to hypoxia. That is, if you were breathing less than 21%, let's say breathing 12% oxygen, somehow your environmental oxygen was decreased, you would hyperventilate. If you even had a little bit of volatile anesthetic on board, you lose that ventilatory response to hypoxia. Your carotid bodies are blocked. The ventilatory response to CO2 is also impaired by volatile anesthetics, but it takes more to do that. If your CO2 goes up, you should hyperventilate. If the CO2 that you're breathing in the ambient atmosphere around you goes up, you should breathe faster. If you have a volatile anesthetic on board, you will not breathe as fast as you would if it wasn't present. Volatile anesthetics are bronchodilators across the board, isoflurane, sevoflurane, and desflurane, but remember that des is an upper airway irritant, and we don't use inhaled inductions with desflurane because of that. Volatile anesthetics attenuate hypoxic pulmonary vasoconstriction, so a patient with one lung ventilation delivering a volatile anesthetic can have some impairment in their HPV. Pharmacokinetics is the next topic, and volume of distribution refers to a mathematical concept of the amount of liters where if you took a drug and a certain dose, gave it to a person, and then measured the plasma drug concentration and took the dose over that concentration that you got, how much would it be diluted in for that to occur? And that's in liters. Those that have a really high volume of distribution are drugs like propofol, lipid-soluble drugs, often hundreds of liters, 200, 300, 400 liter volume of distribution, while low volume of distribution drugs are example like neuromuscular blocking agents, which are big, bulky, ionized molecules that stay in the water space and have a low volume of distribution. Potency refers to the relative dose of two drugs that are needed to have a certain effect. For example, fentanyl is about 100 times more potent than morphine. And efficacy refers to the ability of a drug to produce some certain physiologic or clinical effect. So analgesia would be does it have an efficacy of providing analgesia? At the top right shows a graphic demonstrating the difference between potency, which is affinity, and efficacy, which is activity, in graphic form. And you can see on the y-axis is response, and on the x-axis is the drug dose concentration. And you can see that the farther to the left on the x-axis, the less drug it takes to have a response. That's potency. So A is more potent than B. Efficacy is the height of this graphic. What's the response? And you can see that B has more efficacy. It can reach, if you give enough of the drug, a greater effect. Kinetics, first order versus zero order elimination is the next topic. And the graphic on the bottom right shows first order elimination, what we normally think of with many of our drugs, versus zero order elimination, which we often think of with ethanol ingestion, alcohol. If you have first order kinetics elimination and you have one half-life that goes by, you have gotten rid of 50% of the drug. And if you have 50% of the drug left and you have another half-life go by, you go from 50 down to 25%. And then if another half-life goes by, you go down from 25% down to 12.5% left at 3 half-lives. And therefore, after 3 half-lives, about 87.5% of a drug is gone from the body, and we normally think of it taking at least 3 half-lives for a drug to be gone. Now, zero-order elimination refers to what happens if you go out and drink too much. Your body gets rid of the same amount of alcohol every hour, whether you drank a lot or drank a little. It is called zero-order elimination. It's saturated, and it goes along merrily at the exact same rate, independent of concentration, and you will have a hangover the next day. Pharmacokinetics 2, phase 1 versus phase 2 drug metabolism pathways. Phase 1 refers mainly to oxidation, is what we normally think of. reduction or hydrolysis of lipophilic drugs, but oxidation in the cytochrome system in the liver, CYP2D6 being one of the most important ones. And in the far right, you can see a drug going down the oxidation cytochrome P450 system, where it is converted to a metabolite which is polar and can be excreted in the kidneys. Now, anticonvulsant drugs like dilantin and carbamazepine or tegretol can induce these enzymes and make them more active. Some psych drugs, SSRIs, and some of the HIV treatment drugs can inhibit this enzyme that's important for metabolizing some of our drugs. There are poor metabolizers, about 7 to 10% of Caucasians. There's intermediate metabolizers, and there's some people that are ultra-lipid metabolizers, which, for example, if you give codeine, which we discussed in part 2 of this 3-part series, as being needed to convert to morphine before it is active, if you are unable to do that, codeine does not have an analgesic effect, and that's a poor metabolizer. We pointed out that some people are ultra-lipid metabolizers that have a ramped-up system, extra gene copies, extra enzymes, that they can metabolize it extra and produce more morphine from codeine in a bigger effect than the normal population. So we have some weaker opioids that are metabolized to more potent opioids like codeine, dihydrocodone, tramadol, hydrocodone, oxycodone to morphine, hydromorphone, oxymorphone. And so this enzyme is important for many of our drugs. There's not a significant effect on fentanyl, remifentanil, and sufentanil. So phase 1 reactions are oxidation reactions, and they can be affected by many drugs that can induce or inhibit the enzymes involved in the oxidation system. A phase 2 reaction, if you look to the far right graphic, a drug is often a sugar or sulfate or something is added to it, and the classic is glucuronidation, a sugar added to the molecule to make it easily excreted into the biliary system or out the kidney. So conjugation of a drug with some compound to make it more water soluble, and lorazepam is a good example of that. While midazolam requires oxidation to get rid of it, and many drugs can affect its metabolism, lorazepam undergoes conjugation. Next topic is pharmacokinetics, CYP2D system. We've already pointed out codeine must be metabolized to morphine to be active. Atypical cholinesterases. People can have a problem with pseudocholinesterase, and if they did, such as a dibucane number of 20, they're not going to get rid of succinylcholine like they should. And ester local anesthetics can be affected, but not remifentanil or esmolol. Malignant hyperthermia. If you give someone succinylcholine and volatile anesthetics who are genetically susceptible, they can develop malignant hyperthermia. G6PD, glucose 6-phosphate deficiency, can, when exposed to certain drugs like methylene blue or nitrates, can cause hemolysis of red blood cells. These are some of the triggers, methylene blue and nitrates. And then acute intermittent porphyria, where drugs like barbiturates, diazepam, toradol, etomidate, phenytoin, oral contraceptives, sulfonamides can trigger AIP. Context-sensitive half-time, a keyword from 2019, therefore in purple here, is the time required for the central compartment drug concentration to fall by 50% as a function of the duration of an infusion. So when you hear context-sensitive half-time, it is referring to when you infuse a drug for a period of time. And on the left, you can see drugs like propofol, etomidate, ketamine, have a context-sensitive half-time that's favorable for infusion. That is, if you shut it off after 3 hours versus after 8 hours, sure, it builds up a little bit, but it's not going to build up like thiopental or diazepam, and a very predictable offset or decrease in 50% as a function of the duration of infusion. The context-sensitive half-time isn't as great as diazepam or thiopental. And if you look at opioids on the bottom right, you can see on the y-axis the time to 50% drop in concentration at the effect site, that's in minutes, versus duration that you've infused it. And you can see that remifentanil, whether it's 100 minutes or 600 minutes, 10 hours, it has a very flat context-sensitive half-time. That is, you can shut it off and reliably have a patient awaken after a long period of infusion. Sufentanil also has a favorable infusion pattern, and fentanyl does not. Let's move on to our last topic, which is miscellaneous pharmacology. Anticholinergic side effects. First of all, the central nervous system. Atropine and scopolamine are tertiary amines, NH3, uncharged, and they can cross the blood-brain barrier. Glycopyrrolate does not have that tertiary amine. It is a quaternary amine, NH4+. It's charged and doesn't cross the blood-brain barrier. So atropine and scopolamine, when they cross the blood-brain barrier, can cause CNS effects, dilated pupils, central anticholinergic syndrome, where you have someone who's confused and somnolent and sedated after atropine and scopolamine, and you can reverse it with physostigmine, which crosses the blood-brain barrier and raises acetylcholine levels in the brain. That's antilirium, another name for physostigmine. Tachycardia. Heart rate goes up when you give an anticholinergic agent. Sweating can be reduced and body temperature can go up. The lower esophageal sphincter actually relaxes, and with bronchodilation, you can get increased physiologic dead space. The next topic is anti-emetics. There's lots of different anti-emetics. You can have drugs that are prokinetics, like metoclopromide, that works at the dopamine receptor and causes relaxation of the pyloric sphincter, squeezing of the stomach, and a rise in lower esophageal sphincter tone, such that food in your stomach exits your stomach easier after Reglan or metoclopromide administration. Serotonin antagonists like ondansetron, 5-HT3 receptor effects. Antimuscarinics like scopolamine and atropine work at the muscarinic receptor. Antihistamines like Vistaril work at the histamine receptor. And then aprepitant, a longer-acting, potent nausea agent, in the past was used for chemotherapy-induced nausea, is a neurokinin 1 antagonist. And then we have other drugs that we use in the perioperative period like Decadron, propofol, midazolam, and cannabinoids are associated with reducing nausea and vomiting. Up at the top right shows some risk factors for adults and children, comparing those for postoperative nausea and vomiting. Patient-related factors, things like I have motion sickness, they're female, they don't smoke, and you're going to use opioids, and you're undergoing some type of laparoscopic surgery. That would be a high-risk patient for postoperative nausea and vomiting. In children, the risk factors are a little bit different. Longer surgery, age greater than 3 years, eye surgery, specifically strabismus surgery, and history of PONV or a relative with PONV. Now, consider these risk factors and decide how many drugs you should give, whether you give 1, 2, or 3 multimodal approach of drugs. And with someone with really bad postoperative nausea vomiting, we'll often avoid a volatile anesthetic, give a Decadron and a 5-HT3 antagonist, and scopolamine patch are probably the 3 combinations of multimodal therapies most used by many people. Now, at the bottom, you can see treatment options and what to do according to our guidelines. If prophylaxis fails, let's say you have given Decadron and ondansetron to a person and now they're nauseated and throwing up in the recovery room, use an antiemetic from a different class. You might want to go to promethazine or aprepitant or something like that. And re-administer those other drugs only if greater than 6 hours after recovery room. Don't re-administer dexamethasone or scopolamine if you've already given them. Those are long-acting. So don't just repeat the drugs that you gave. Look for another class if someone's throwing up in the recovery room. Anti-emetics, QT prolongation is a potential problem. The graphic on the top right shows the QT interval. And droperidol and our 5-HT3 antagonist can prolong the QT interval and potentially increase the risk of the dysrhythmia torsades de pointes. QT corrected is normally less than 440 milliseconds. When it's greater than 440 milliseconds, that's considered prolonged QT interval. And patients with congenital or acquired prolonged QT interval may be on a beta blocker because that's the treatment for prolonged QT interval. Hyperglycemia Well, what about antiemetics in those type of patients like diabetics? We know that dexamethasone, a glucocorticoid, can increase the blood sugar and may complicate diabetic management in someone in the perioperative period. Parkinson's disease, if you're choosing an antiemetic, you're going to avoid dopamine blocking agents. They're living on their last dopamine receptors, and if you block them, they may become akinetic, unable to move. So droperidol, chlorperazine, metoclopromide, all dopamine blockers. Glaucoma, a key word in 2019, therefore in purple here, was avoid anticholinergics such as atropine or a scopolamine patch with acute angle closure variant of glaucoma, because if you dilate their pupil and fold back the iris against the canal of Schlemm and block the outflow of the fluid in the eye with these anticholinergics, they can get acute rise in their intraocular pressure and potentially lose an eye. So scope patch would be contraindicated in someone with acute angle closure glaucoma. Metoclopromide or Reglan and its gastric effects, it has dopamine blocking effects, so avoid it if someone has Parkinson's disease. We usually use it to help the stomach empty because it stimulates gastric motility. So if someone has had a pyloroplasty or intestinal anastomosis, probably not a great idea to make that gut work more and create higher pressures inside when they've had an anastomosis done that could break down. It does increase resting tone of the lower esophageal sphincter and relaxes the pyloric sphincter, so things tend to move down rather than regurgitate up. It has no clinically relevant antiemetic effects, so it's not a great antiemetic in and of itself. There's some side effects. They can have extrapyramidal reactions. Benadryl is one of the treatment for extrapyramidal reactions. It can cause sedation and can cause hypotension, bradycardia, or tachycardia if administered intravenous and rapidly. H2 receptor blockers in gastric pH is the next key word. We don't prophylactically premedicate every patient with an H2 blocker, even though aspiration is always a worry in anesthesia. But we should consider an H2 receptor blocker in the high-risk patients like parturients, morbidly obese with GE reflux, and anticipated difficult airway, because difficult airway management is associated with aspiration. Now, when you give an H2 receptor to someone, it's not going to alter the pH of the gastric fluid that's present already there, but it's going to alter the gastric fluid that is secreted into the stomach after the time it's administered. So it's not an automatic fix for the pH of the stomach, and it doesn't facilitate gastric emptying like Reglan does. Its onset, pretty slow, 30 to 60 minutes. It's going to last about 12 hours. Orally, about an hour or more for it to kick in. If you decide to use a PPI, proton pump inhibitor, instead of an H2 receptor blocker, remember that PPIs take longer for onset but last longer in their effects. Next key word is benzodiazepines and their respiratory effects. Benzodiazepines work through the GABA receptor, like many of our IV anesthetics. They do depress ventilatory response to carbon dioxide, not as much as opioids do, but some depression of ventilation. Occasionally, if you bolus midazolam or lorazepam, you can get transient apnea. When administered low, though, without another opioid along with it, rarely do you get into problems. The metabolism is different between midazolam and lorazepam. Midazolam and Valium require the CYP system. This is phase 1 reaction or oxidation reactions in the liver, while lorazepam undergoes glucuronidation, or putting that sugar attached to it and then excreting it renally. And if you combine opioids and benzos together, you can get into problems with respiratory depression more than if they were singularly used. Flumazenil, the reversal agent for benzodiazepines, is a competitive antagonist at the benzodiazepine receptor, which is the GABA receptor, which is shown on the far right with the red arrow showing where flumazenil acts, right near the benzodiazepine receptor. Its elimination half-life is about 60 minutes. Therefore, if someone was given lorazepam, a long-acting benzodiazepine overdose, and you wanted to reverse it and you gave them flumazenil, 60 minutes later they might start to get sedated again, and you may have to repeat the dose of flumazenil or even do an infusion. This is similar to the concept with naloxone or Narcan reversal of opioids, where the half-life of Narcan is only about 60 minutes also, and you can get sedation or inhibition of respiration as a long-acting opioid remains after the reversal agent is gone with its effects. Flumazenil lacks intrinsic agonist effects, which means that if I gave you flumazenil, you would not even know you got it. It wouldn't affect your cardiovascular, your respiratory, or central nervous system. It doesn't alter MAC. Only if a benzodiazepine is present, then it will reverse the sleep-inducing effect, the muscle relaxation effect, the amnestic effect, the sedation effect, the anxiolytic effect, depending upon the dose that you give. And you can actually precipitate withdrawal in someone who's benzodiazepine dependent. Be careful if someone is chronically taking high doses of benzodiazepines and you give them flumazenil, there are risks to precipitate a withdrawal and possibly even seizures. Next topic is dexmedetomidine, or Precedex, and its cardiovascular effects. And dexmedetomidine is being used more and more in the perioperative period in an attempt to reduce opioid use, to reduce postoperative delirium, etc. But let's focus in on its cardiovascular effects. Clonidine and dexmedetomidine are selective alpha-2 agonists. Dexmedetomidine is even more selective than clonidine for the alpha-2 receptor. And when you have agonism at the alpha-2 presynaptic receptor, norepinephrine release is inhibited, both centrally and peripherally, so in the brain and in the spinal cord. And you get sedation because of its central effects. You get a decrease in MAC. You get some analgesia or morphine-sparing effect. Respiratory drive is preserved, and that's part of the reason we like using Precedex or dexmedetomidine infusions for sedation in the intensive care unit. And you can keep it going right through weaning to extubation, as opposed to propofol or midazolam fentanyl sedation, where you would often shut that off hours in advance and then have a person trying to be weaned and extubated while they're not sedated. Dexmedetomidine can be continued through wean and extubation. Dexmedetomidine, because it's inhibiting norepinephrine release, decreases sympathetic activity, and vascular resistance and heart rate can go down. So we have to be careful in patients that were already hypotensive or have heart block issues. It can worsen those. If you administer dexmedetomidine as a rapid bolus over, let's say, less than the recommended 10 minutes, definitely, but let's say you gave it over 30 to 60 seconds, a normal 1 per kilo dose, you can get transient and paradoxical hypertension, where the blood pressure actually goes up instead of going down. And the explanation for that, this paradoxical effect, is that it's probably stimulating alpha-2 receptors in vascular smooth muscle and causing vasoconstriction. There's no rebound effects seen after discontinuing dexmedetomidine infusion, so you don't have to wean it over long periods of time. Phenoldiprem, not used very much anymore, but is an IV antihypertensive drug that stimulates the dopamine receptor, DA1, without significant effect at the D2 alpha or beta receptors. And so it's dilating arterial beds and can be used to induce hypotension, to treat patients with hypertension, while because of its DA1 effect, maintains renal perfusion, actually increases renal blood flow. So this seems like it'd be a great drug to use perioperatively where you're trying to control blood pressure in someone with renal insufficiency. It has diuretic and natriuretic, water and salt losing properties. Dantrolene and its pharmacology. Dantrolene, we use for the treatment of malignant hyperthermia, the main use of dantrolene. And it blocks calcium release from the sarcoplasmic reticulum. So in the graphic at the top right, you can see a sarcoplasmic reticulum in yellow, a ryanodine receptor, and in an MH episode, the ryanodine receptor is defective. Your trigger of succinylcholine or volatile anesthetic has caused it to spew calcium into the space of that muscle cell, and actin and myosin filaments cross-link, and you get rigor, heat production, carbon dioxide production, acid production, so lactic acidosis, hypercarbia, hyperthermia, and this muscle rigor that is not broken by non-depolarizing or depolarizing muscle relaxants. It is at the muscle level, not at the neuromuscular junction level. So all this calcium builds up, and then usually the sarcoplasmic reticulum takes up that calcium, as does the mitochondria. Now, dantrolene in an episode of MH stops the ryanodine receptor from spewing out the calcium, but doesn't block the reuptake of calcium. So the calcium intracellular level, the level of such goes down with treatment with dantrolene. Prophylaxis with dantrolene, even in someone who's MH susceptible, no longer recommended. Patients will get sedated and some muscle weakness potentially and nauseated with dantrolene. That's a side effect. If you use dantrolene, its contraindication is to add a calcium channel blocker, specifically verapamil. The combination can produce hyperkalemia as well as myocardial depression. So dantrolene and verapamil, contraindication to use together. And as I mentioned, if you give dantrolene to an awake patient, they can get weak, GI upset, sedation, and if you administer it over time, some abnormal liver function tests. Dantrolene can be used not only for MH, but a treatment for neuroleptic malignant syndrome, that slow onset MH that's associated with antipsychotic medications. The next key word is anaphylaxis. Anaphylaxis can type 1 IgE mediated, where the immunoglobulin attaches to mast cells and basophils and causes them to release the junk that's inside of them. This antigen antibody reaction is anaphylaxis. The anaphylactoid reaction is when you have non-immune mediator release. That is, you don't have the IgE attached to these. It causes a release without the antibody-antigen interaction. Mediators are things like histamine, which make capillaries more permeable and leaky. They cause vasodilation, and histamine causes bronchoconstriction. Leukotrienes that occur in higher concentrations when you have anaphylaxis cause capillaries also to be leaky, also to cause bronchoconstriction. There are also negative inotropes and coronary vasoconstrictors, and prostaglandins can cause bronchoconstriction. Therefore, when someone is having an anaphylactic episode, they often have hives from fluid leaking out of vascular endothelium, itchiness, low blood pressure, low volume intravascular, even laryngeal edema, and some bronchospasm and arterial hypoxemia. Plasma histamine goes up and then goes down very quickly, returning to baseline in 30 to 60 minutes, while plasma tryptase, a blood test that you can do for the diagnosis of anaphylaxis to help you with it, often post-event, but tryptase comes from mast cells and it increases within 1 to 2 hours and remains increased for a longer period of time than histamine. So tryptase is a blood test for assisting in the diagnosis of anaphylaxis. How do we treat anaphylaxis? Epinephrine, often in very low amounts, like 10 mics intravenously initially, and then ramping up as needed. The anaphylactic episodes in the perioperative period are most associated with antibiotics and neuromuscular blocking agents like rocuronium and succinylcholine. If someone has a history of penicillin allergy without anaphylaxis, we now are using cephalosporins, even though there's always been this risk and worry about the cross-reactivity between penicillins and cephalosporins. Why do we use epinephrine for the treatment of anaphylaxis? Early on, it's important to start it when you believe this is an anaphylactic episode, because epinephrine increases intracellular cyclic AMP. Why is this good? Because this restores membrane permeability and it stops those vasoactive mediators from being released from the basophils and mast cells. So it not only is raising blood pressure, that is epinephrine, it's not only bronchodilating to relax the bronchial smooth muscle and treat the bronchoconstriction from anaphylaxis, but it's stopping the event itself by decreasing the release of vasoactive mediators. And epinephrine, early treatment for anaphylaxis. Ketorolac and renal function, Toradol. Nonsteroidals block prostaglandin-mediated effects of renal blood flow. So in the kidney, what they do is they block prostaglandin production. So if there's less prostaglandins, there's less of the afferent arterial dilation in the kidney and less blood flow going to the kidney. So someone with acute renal insufficiency or ischemic acute renal failure, boy, that would be a bad person to be giving Toradol to. So the elderly, critically ill, patients with heart failure, renal or hepatic dysfunction, these patients are predisposed to having ketorolac-induced renal dysfunction. And the production of this renal dysfunction more likely in the factors listed here, including advanced age and coexisting renal hypoperfusion, a patient who has pre-existing hypovolemia, who's septic, undergoing major surgery, and has other risk factors for acute renal failure. Some of the other problems with ketorolac, it can cause proteinuria, interstitial nephritis, and it's recommended not to exceed several days of IV or IM dosing. Don't just keep it going for weeks on end. The next topic is herbals and supplements in the perioperative period. It's recommended, if you have time, to discontinue herbal therapy 7 to 14 days before surgery. One exception is valerian, a CNS depressant, which if you just stop, you can run the risk of apparently seizures. However, mandatory discontinuation of herbals or canceling an anesthetic when they've been continued in the preoperative period is not supported by evidence. So if someone comes to the pre-op period and says, what are you taking? And they list their meds and include an herbal, you don't have to cancel the surgery, but it would be wise, if possible, to stop it a week or two before surgery. They're also not a contraindication to neuraxial anesthesia, despite the fact that the G herbals, garlic, ginseng, ginkgo, ginger, the ones that start with the letter G, can interfere with anticoagulants or antiplatelet drugs, and platelet function itself may be impaired by these G herbals. Ginseng can actually lower blood sugar levels, and if you have someone who takes ginseng who's been not eating, there is a risk of hypoglycemia in that fasted patient. A gap in knowledge on the in-training exam 2019 was related to ginseng and garlic, G herbals, and the fact that it is not a contraindication to spinal anesthesia, despite the fact they can inhibit platelet aggregation. The ASRA guidelines 2018 say that we recommend against the mandatory discontinuation of these medications or avoidance of regional anesthetic techniques. And so if someone comes in and has taken ginseng or garlic, go ahead with the spinal, go ahead with the epidural. And if you have questions about the ASRA guidelines, there is a application that you can put on your phone, ASRA Coags 2, that can allow you to easily look at coagulation drugs, including herbals, and what the ASRA guidelines are related to them. The next key word is diuretics. Lasix, the first one, or furosemide, it has an onset within about 5 minutes and starts to peak in about 20 to 60 minutes and lasts for a couple hours. It inhibits sodium and chloride reabsorption in the thick ascending limb, and sodium and calcium and magnesium are all excreted. So not just sodium and water goes out, but calcium and magnesium. And you get a hypotonic urine, meaning you're losing water. They also venodilate before the diuresis actually occurs. So if someone has heart failure and you blast them with a dose of Lasix, your venodilation often helps them because the heart becomes unloaded, and then the diuresis helps them to lose water. Complications of Lasix include metabolic alkalosis. When you have someone in the ICU who you've been given Lasix for long periods of time, it's not uncommon to draw blood gas and see a high bicarbonate and what we call contraction alkalosis. Hearing loss, hyperuricemia, and the classic hypokalemia associated with diuretic use are associated with Lasix. Mannitol is an osmotic diuretic, stays intravascular, draws fluid in, and then pulls it out through the kidney. You can get volume depletion from it and electrolyte imbalances because you tend to lose sodium, potassium, and magnesium along with water. Not very effective in prevention of acute renal failure, but we still often use it in renal transplantation, at reperfusion time, or in patients that aren't urinating well while they're on bypass. Sometimes mannitol will be put in the prime. Mannitol is used to decrease intracranial pressure. It acts in about 30 minutes. Its maximal effect is in about 1 to 2 hours. But you have to remember that mannitol initially will raise intravascular volume as it draws fluid from the interstitium, like that brain that's edematous and has an intact blood-brain barrier. You give mannitol, it can draw fluid out of the brain, but it raises intravascular volume first. And if someone has a bad heart, you could actually precipitate heart failure. Diuretics 2, first looking at where various diuretics work, and they're color-coded in this slide. Thiazides, green, work at the distal tubule. Acetazolamide diamox, the light blue, is a carbonic anhydrase inhibitor, works at the proximal tubule. And then spironolactone, a potassium-sparing aldosterone antagonist, works at the purple at the distal tubule. So let's look at the thiazides first. They inhibit sodium transport in the distal convoluted tubule. They're not very effective when you have really bad kidneys, and so we move from a thiazide diuretic up to Lasix or Bumex when someone's kidneys aren't working very well. They can cause dehydration, hypokalemia. The classic person on a thiazide diuretic that comes in with a potassium of 2.8, and you go, oh, should I cancel this case or what? They can cause metabolic alkalosis, hypercalcemia, and hyperuricemia. And that hypercalcemia and hyperuricemia are somewhat uniquely associated with thiazides. Now, acetazolamide or Diamox is used for glaucoma treatment, for acclimatization to high altitude, are two of the uses, and it inhibits carbonic anhydrase, that enzyme involved in CO2 and water and carbonic acid and bicarbonates movement in and outside of cells. The proximal renal tubule is its site of action, and it doesn't allow bicarbonate to be reabsorbed. So you pee bicarbonate. If you pee bicarbonate, you're going to get an alkaline urine, but then what's going to happen in your blood? It causes a metabolic acidosis. And you can also lose potassium and sodium. In the case of glaucoma, it reduces aqueous fluid production in the eye, therefore that's why it's used. And at high altitude sickness, it shifts the oxyhemoglobin curve and induces hyperventilation, which is a normal compensatory response to high altitude, and it can be beneficial in those situations. Spironolactone is an aldosterone antagonist working at the distal nephron, where it inhibits sodium and potassium excretion. What happens is it is a weak diuretic, and because it has an effect on potassium reabsorption, it can actually cause hyperkalemia. It's called a potassium-sparing diuretic, and hyperkalemia can ensue when aldactone, that is, or spironolactone, is utilized. Anticoagulant action, the last two slides of our series here. Warfarin, where does it act? It inhibits the synthesis of vitamin K-dependent clotting factors. Those are 2, 7, 9, and 10. And it also affects protein C and protein S. And how do we monitor warfarin's effect? A PT, INR, of course. And there at the top right shows warfarin's effect on factor 2, 7, 9, and 10. Low molecular weight heparins bind antithrombin 3, which then accelerates antithrombin's inhibition of factor 10A. We monitor low molecular weight heparin. We can monitor it by anti-factor 10A activity. Don't do it very often. We don't monitor PT or PTT INR. Remember, with heparins, we monitor PTT. Fondaparinux inhibits 10A directly. Here we have an example at the far right of other factors affecting 10A. We have direct thrombin inhibitors like dabigatran, which we're going to talk about next. Factor 10A inhibitors with like abixaban and rivaroxaban. Note that fondaparinux inhibits 10A via antithrombin, not a direct thrombin inhibitor, so it has less chance of hit than does heparin and doesn't increase the PT and PTT. Heparins, the classic unfractionated heparin as opposed to the low molecular weight heparin, it works through antithrombin 3. When it activates antithrombin 3 then goes along to inactivate thrombin, 10A, and other proteases. And we know that we monitor heparin classically with a PTT and in cardiopulmonary bypass cases often with an ACT. Anticoagulant action number 2, clopidogrel or Plavix. We have drugs that are used to treat clotting disorders and to give to patients with, for example, drug-eluting stents in place in their coronary arteries to try to keep them from occluding. Plavix is one of those. It's a prodrug requiring activation by CYP2 system, and clopidogrel acts on the ADP receptor on the platelet membrane. It's an irreversible inhibition, and platelet effects doesn't allow platelets to adhere together. Bivalirudin, or Angiomax, is a direct thrombin inhibitor. And dabigatran or Pradaxa is an oral direct thrombin inhibitor. So let's go over to the graphic first and put this into perspective, because these are complicated and hard to remember, in my opinion. Anticoagulants in red up at the top, and then the ones listed here include direct thrombin inhibitors, things that don't require antithrombin 3 like heparin does, and that would be dabigatran and argatroban, lepirudin. And then indirect thrombin inhibitors are things like heparin and fondaparinux. Those require antithrombin 3 to have their effects. And then the vitamin K reductase inhibitors, warfarins are classic one, 2, 7, 9, and 10 affected. And then those that affect 10A directly, rivaroxaban and apixaban. And then we have things that affect the platelets, like aspirin, COX inhibitors. We have glycoprotein 2B3A inhibitors, like abciximab, eptiftamide, and ADP inhibitors like Plavix or clopidogrel. And then we have thrombolytics that can be used to treat arterial and venous thromboses, things like streptokinase and others, which are plasminogen activators. So let's go back to bivalirudin and dabigatran, our last two here. Bivalirudin, or Angiomax, is a direct thrombin inhibitor and does not require antithrombin 3 to have its effect. It is renally cleared in about 25 minutes and often used when anticoagulation is needed in a patient, but they have developed HIT with heparin, that is heparin-induced thrombocytopenia. And you go, I need to have them anticoagulated, but I can't use heparin. And bivalirudin works by directly inhibiting thrombin. We monitor ACT or APTT or thrombin time for the effect of bivalirudin. Now, like bivalirudin, argatroban is a direct thrombin inhibitor, but it requires the liver to get rid of it. So if someone had renal insufficiency and we needed a direct thrombin inhibitor, argatroban might be a choice. And it also can be used when HIT is present. So these drugs like bivalirudin and argatroban are like secondary drugs usually in patients where you can't use heparin for some reason, usually because of heparin-induced thrombocytopenia risk. Dabigatran or Pradaxa, if someone comes in who's on this, who has a hip fracture, it's a real problem. These patients who are taking it, it is an oral direct thrombin inhibitor with a half-life of 12 to 14 hours, prolongs the PT-PTT INR, but not linearly, so it's not monitored. And that's one of the reasons why people like it, because they can take it and don't have to go get their PT INR checked on a regular basis. This ends our pharmacology review. It is part 3 of a 3-part series. Keyword review. I wish you the very best. These pictures are from a trip I took from Seattle to San Francisco alone on my bike with a tent and a sleeping bag, 1,000 miles down the Oregon and California coasts. A beautiful trip, and I wish you a great day.